This is Rural Health Leadership Radio.
Episode 180, a conversation with Paul Moore, Senior Health Policy Advisor with the Federal Office of Rural Health.
What I see in this right here is an opportunity to both bend that healthcare cost curve and, while we're doing that, improve the health and reduce the burden on a million of folks suffering or soon to suffer with COPD.
Welcome to the Rural Health Leadership Radio with your host, Dr. Bill Oxier. Each week, Dr. Oxier has a conversation with a different rural health leader to discuss what's working and what's not working in rural health, along with other topics of interest to rural health leaders. Rural Health Leadership Radio's goal is to improve health in rural America by providing a simple, no-cost means to share information and connect rural health leaders from around the country. And now, here's Dr. Oxier with today's guest.
Hi, everybody. I am your host, Dr. Bill Oxier, and welcome to the Rural Health Leadership Radio podcast. I hope your year is starting out well. There's a lot of positive things already happening in 2020 as it pertains to rural health leadership. One of the hats that I wear is that of Program Director for the NRHA Rural Hospital CEO Certification Program, which launches its first class in February. And so far, we have had over 150 applications or inquiries of interest into that program. Now, that is exciting that so many rural hospital CEOs and aspiring rural hospital CEOs want to enhance their skills with professional development. And if that's something that you might be interested in, just let me know by sending me an email. You know, something else that is exciting as we start the new year is the fact that I'm going to start hosting a monthly webinar. This will be like Rural Health Leadership Radio 2.0 because we'll be talking about rural health leadership, but we'll also have the opportunity to have a conversation. So I hope you will join me on one or all of those webinars. Be on the lookout for information about that. But on to today, I'm excited for our guest to share information that will assist rural health leaders with best practices as it relates to chronic disease management, COPD in particular. Now, this interview took place a few months ago. It was part of a 7-part series that the National Rural Resource Center put together on chronic disease management, and I want to thank them for allowing me to be a part of that and for making today's episode possible. Last week, we heard from Grace Andorny Koppel. Today is the second interview from that 7-part series. So on to today's guest. Today, we're having a conversation with Paul Moore. Paul is the Senior Health Policy Advisor with the Federal Office of Rural Health Policy, Health Resources and Services Administration, also known as HRSA. Welcome to the Rural COPD podcast, Paul.
Thank you so much, Bill.
Well, let's get right to it. Tell us about yourself. Who is Paul Moore? What's your story?
Well, in reality, I'm a country boy at heart. In fact, I was thinking I was over 50 years old before I ever even lived in a metropolitan county.
Oh, wow.
I graduated from pharmacy school in 1977, and pharmacy has been a great profession and a wonderful springboard for all aspects of my career. But that's not where my healthcare experience began. I actually like to tell folks I grew up in rural healthcare, even though I didn't know back then that's what it's called.
Yes.
My first non-agricultural job was at 16 years old working in the nursing home that my grandmother started back in the 1950s by taking neighbors into her home. And Bill, she built that into an 88-bed nursing facility before she retired over the next 3 decades.
That's incredible.
Yeah. And I've been given many wonderful opportunities and experiences. There's no way around that. But it's those experiences that inform my current day job as Senior Health Policy Advisor. Whether I'm reviewing a proposed regulation or working across HHS on a national action plan or maybe with a sister agency on an innovation project, my thought always turns back to how is this going to affect those rural patients and providers back home in rural America?
Well, that's a great lens to for all rural health advocates anyway. It's a great lens to look through. So thank you for the work that you've done and are doing in rural health. You know, on my Rural Health Leadership Radio podcast, I always ask each guest what their definition of leadership is. So I thought I would continue that tradition here. What is your definition of leadership, Paul?
Well, like we all need another definition of leadership. I'm looking across my office and there are shelves full of books on leadership.
Yes.
So knowing that, there's nothing I could say that will be original with me, but there are some definitions that do resonate personally with me. Thinking about it, one definition of leadership that I like is, I think it goes like this: a process ordinary people use when they are bringing forth the best from themselves and others. And that's because I really do see leadership more as a process than a position.
Yes.
And it's a process that plays out consistently day after day, day in and day out. I also recognize that leadership occurs at all levels of an organization, not just at the top, not just in the C-suite. There's opportunities and need for leadership at all levels. So that's one definition I really like, a process that ordinary people use when they're bringing forth the best from themselves and others. Another concept I personally relate to about that process is how I see real leadership, or the real work of leadership, taking place. I see the real work of leadership being a matter of making commitments, delivering on the commitments you make, and maybe most importantly, securing commitments from others. Effective leadership also happens by example, not mandate. And in fact, as it happens by example, if it doesn't result in bringing forth the best from yourself and from others, in my opinion, it likely isn't leadership.
Well, I do like the way you focus on process, Paul, because, one quote that I read recently is that leadership is something you do with people, not to people. So that, kind of goes along with that process sort of thing. So excellent observations. You're right. There are a lot of books on leadership. There's a lot of definitions of leadership, but it's always interesting to hear the different nuances that resonate with different leaders, such as yourself. I belong to the American College of Healthcare Executives, and they're always issuing reports about hospital CEO turnover, and Becker's Hospital Review, same thing. It's the tenure is very short, under 4 years, I believe, always hitting in double digits, the annual turnover rate of CEOs that's involuntary. You've been a hospital administrator. Do you have an opinion about what's going on here?
Yeah, I have some thoughts about it, and I might even venture a guess that, I think you said it's less than 4 years. I would almost venture a guess that in small rural hospitals, it's even shorter than that. And I also know that while each case is unique, in each community, in each small rural hospital, there are probably a number of contributing factors in common, especially when you're talking about the small rural hospitals like I had the privilege of running. As I think about the challenges before a committee or a community in finding someone to run their hospital and hiring a CEO, I recognize that they have limited recruitment possibilities in small towns. Not everybody wants to live in a small town, but because the pool is smaller of possible candidates, that can lead to interviewing and looking at candidates where they have inadequate preparation or maybe inadequate experience. I've known, in fact, this was my situation of communities where maybe they've had an experience or something with a larger system, and they decide, let's just go locally. Let's hire someone locally. Let's get someone well thought of in the community that has good people skills. They might have a clinical background or a business background, but at that point, that's more important to them than the fact that they have any formal training for running a hospital. I've also seen in small rural hospitals where they find a hospital CEO that's maybe in a larger facility or something, but they're getting near retirement age, and so they're looking to slow down a little bit. And this smaller hospital is, they're not planning on being there a long time, but they can bring experience and leadership to a small rural hospital. There's a third situation that I've seen, it's what I call the bouncing CEO candidate. This is the guy or gal with, 36 years experience on their resume, but when you look closer, it's really a candidate with 3 years experience 12 different times, because they move around a lot. And, I was thinking, you probably don't want to be hospital number 13 in that situation.
No, that's an unlucky number, no matter how you slice it in that situation. Yeah, it's very interesting. Thanks for your perspective. on that. So what advice would you share with a potential leader that is to set them up for success if they when they enter into a new position?
Wow, that's a great question. You know, I would probably share my understanding of what I call the two essential and, in fact, inseparable aspects of leadership, that being authority and responsibility. Now, most folks understand responsibility. In fact, that's usually pretty well outlined in the job description, you know, what the job entails, what's going to be expected of you, all that kind of stuff. What many folks don't understand or may not understand is the nature of authority. And I find that is where much frustration can surround the job description, the fulfilling of that responsibility. In my opinion, authority is not bestowed or assumed just because a person is in a position of leadership. Authority, and this is a lesson that has come to me personally, and I truly believe this, authority is derived from being under a higher authority. Now, that can sound real philosophical, but let me give you an example of what I'm talking about. The CEO of a hospital derives his or her authority from his governance board. And the board derives their authority from their bylaws. And the bylaws need to at least align. In other words, the bylaws derive their authority from the law, and the law from the Constitution. And if you think about it, even our Constitution was crafted by our founding fathers in such a way as it derives its authority from a higher authority, that being the will of the governed. So I say all that to say this: when a person in a position of leadership grasps this concept that number one, I have authority, but not to do whatever I want to with it. I have authority because of the fact that I'm under a higher authority. When they get in that position, they don't need to fear having their authority undercut or gone around. And that's a good place for a leader to be.
I love that, actually. You know, I've never thought about it in that way. I think that's some fresh perspectives to bring on understanding and looking at leadership. So thank you so much for sharing that with us. I may steal that from you if you don't mind.
Help yourself.
Thank you. So today we're talking about COPD. Why are you here with us talking about COPD today?
Well, I appreciate the opportunity. And I can tell you, I guess it's because the topic of COPD is personal with me. From my own experience, not only as a community pharmacist for over 30 years, but also as a family member. See, I've watched the progression of the disease as it takes away the lifestyle of people, progressing over time from just a bothersome shortness of breath upon exertion to where I've seen a family member filled with anxiety, fiercely fighting for that next breath, hanging on to the edge of consciousness, if you will, not being sure if they're going to get that next breath in. And I'm also talking about it because of what I perceive as a lack of national attention on COPD. Oh, I know that healthcare providers are aware of the prevalence. I remember as a rural hospital administrator, I knew it was always one of the top 3 discharge diagnoses in our facility. But Bill, I would also venture a guess that most of your listeners know someone personally who is affected by the disease. But the problem is that because of that, COPD is so ubiquitous that it doesn't make the headlines or for that matter of fact, garner the funding that supports efforts around some of the other diseases.
Yeah, you know, with your observation about you would guess that everybody in the listening audience knows someone personally who is affected by the disease. That certainly applies to me, family members, friends that have been diagnosed with COPD. So that's definitely true. So I understand that. Thank you for that perspective. What do we know about COPD?
Well, we know that roughly 16 million Americans are living with a diagnosis of chronic obstructive pulmonary disease. And we also know that many more have the condition, but it's not diagnosed yet. They may not even know it. We also know that while mortality from other chronic conditions has decreased, in other words, the picture's gotten better, mortality from COPD has doubled in the last 50 years.
Wow.
It's going the wrong direction.
Wow.
Yeah. COPD is the 4th leading cause of disability in the United States. And while we should never lose sight of the personal suffering associated with the disease and the burden that it causes the person that has it, It also imposes an enormous burden on the nation's healthcare system. I've heard that the cost of COPD-related patient care has been projected to increase to $49 billion by next year.
That's billion with a B, right?
Billion with a B.
Wow, that's incredible. So how is COPD different in rural America?
Well, COPD is far more common, and in fact, mortality is far higher in rural populations than in urban populations. Patients, especially those living in rural areas, tend to be unaware of COPD, and because of this, they tend not to recognize symptoms until they have lost substantial lung function. In other words, it's accessing healthcare, accessing treatment later, and therefore they're in a worse situation. In addition, COPD is underdiagnosed in primary care settings. Most cases of COPD are identified during what we call an acute exacerbation. That means it's resulting in a hospitalization. For rural Americans living with COPD, there are also differences in the availability and the allocation of healthcare services. Not just COPD, that's a rural thing.
Yes.
There's a disparity between access to healthcare in rural and urban. But we see that issues such as access to specialty care, that would be like a pulmonologist, or like specialty care like pulmonary rehabilitation, lack of access to those affects their ability to manage the disease effectively, where that lack of access might not exist in the urban area.
So the way it's different, if I heard you correctly, the way it's different in rural health is it's more common. More people are dying, and it's an underdiagnosed problem, in addition to the fact of healthcare access for the proper treatment. Does that summarize what you just said?
It does, and it's multifactorial. There are other reasons. We know that smoking rates are higher in rural areas than they are in urban areas. And this is a disease that is definitely affected by smoking or a history of smoking, but it's not a smoker's disease. At least 25% of the folks that have been diagnosed with COPD never smoked in their life. So there are a number of factors. I'm not giving you an exhaustive list of factors. Those are factors, but there's a number of them that is why it's worse in rural than it is in urban.
Can you talk about workforce issues?
Yeah, now I will tell you this. The many factors that result in what I'd call a maldistribution of healthcare workforce in rural areas compared to urban areas is a broader discussion than just its impact on COPD. But it is also a key factor in rural COPD care. I can give you an example.
Okay.
Current regulations under Medicare can be burdensome for rural health facilities that offer pulmonary rehab services. They're specifically with regard to who can provide direct supervision for such programs. It's because of this. As prescribed by law, Medicare requires that a physician be available for each pulmonary rehab session. And since Congress stated that services must be physician supervised, non-physician practitioners, such as physician assistants, nurse practitioners, they're unable to serve in the supervising role for the pulmonary rehab services, even though maybe they're allowed at times to supervise other services under separate legal authority, like a state law or something like that. But because the wording is precise, physician supervised, that means that the reality, being out there in rural America, there's a lot more physician assistants and nurse practitioners providing primary care that they're not allowed to supervise the pulmonary rehab. So
wow.
It increases the burden there.
Wow. Is there a way to work through that through telemedicine at all?
That telemedicine can sometimes serve as a proxy, and that's creative thinking on your part. I like that.
Okay, sorry.
It's not something that they could do right now, because the thought being, while they're having pulmonary rehab, and it's the same in cardiac rehab, that someone needs to be there to rescue the patient should something go south.
Gotcha.
And so telemedicine would not necessarily be the concept for that. It would be a way to access specialty care like pulmonologists, though.
Okay.
But there is a policy perspective at work here. And in fact, during its September 2018 meeting, the National Advisory Committee on Rural Health and Human Services took on this policy issue. And actually, in their report, they state this: although the committee recognizes the intent of Congress to improve access to pulmonary rehabilitation services, the committee is concerned that such a requirement may actually be difficult for rural facilities to fulfill, given the shortage of rural health professionals. And, like I mentioned a while ago, since the availability of non-physician providers reflects the clinical resources and reality in areas, the committee came up with a recommendation that said the committee believes that direct physician supervision needs to be expanded to include other primary care providers, and they recommended that the Secretary work with Congress to expand that direct supervision of pulmonary rehab to include physician assistants, nurse practitioners, and other primary care providers under a general supervision of a physician. Something like that would hopefully help us get more pulmonary rehab in rural areas.
Yeah, it sounds like there's a real need there. So that's good that something is moving forward in the policy aspect of this. So, Paul, what scares you the most about the future of COPD care?
Well, very pragmatically, that it's never something that I personally have to suffer with.
Yes.
The thought of, I've seen enough of it, and the thought of having to live with that is scary. I guess beyond that, in a nutshell, would be that nothing changes, that the status quo continues, that we don't take this opportunity we have to improve treatment and improve outcomes in rural areas.
Yes, that would be scary if we don't make any progress there, and it'd be scary to be diagnosed, that's for sure. Well, what gives you hope?
Actually, there's a number of things that give me hope. First, there's the fact that now CDC is looking at data on a national level, and they're cutting it by rural and urban. And there's now data showing that there's a disparity in rural versus urban mortality and burden when it comes to COPD. Now, you say, Paul, that sounds like bad news, not good news. Yeah. Well, the point is this data brings light on the need to change the way we're doing things and changing, focusing resources. When it's worse in rural areas, maybe it needs some more attention in rural areas. A second thing that gives me hope is this: I'm encouraged, having met some strong advocates for that change I'm talking about there, both inside and outside of government. There's providers and patients, and those folks are using their voices and their experiences. And the fact is, I see it getting some traction nationally. And I guess finally, and this may seem a little out of place here, given how personal I know the experiences are from those suffering with COPD. But one thing that gives me hope about the future of COPD prevention and treatment is a separate change that I already see underway. And that's just this: our healthcare system is changing the way that healthcare services are being paid for. Now, what's happening is they're moving away from just paying for services to paying for outcomes. Some fairly recent examples of that are the development of the accountable care organizations and some demonstrations that are going on with global budgets. And because of that changing in payment policy, I'm optimistic that in a payment environment where the providers no longer have to focus on doing what you can get paid for, but rather they're incentivized to provide what will make the most difference, that in that environment, we'll see more and more investment in proven preventions and treatments, for example, pulmonary rehabilitation.
Yeah, that is exciting, very exciting. And it sounds like we've got a lot of momentum headed in that direction. So thanks for sharing that with us. We've talked about a lot of stuff in the short time we've been talking here, Paul. If our listeners only take one thing away from our conversation today, what should that be?
Great question. I guess maybe that we should seize this opportunity that we have to both bend the healthcare cost curve. I mean, we hear that at least once a day.
Yes.
How the cost of healthcare is just unsustainable, and that we need to do something about that. What I see in this right here is an opportunity to both bend that healthcare cost curve and, while we're doing that, improve the health and reduce the burden on millions of folks suffering or soon to suffer with COPD. And because, Bill, more than our share of those folks will live in rural areas.
Paul Moore, Senior Health Policy Advisor with the Federal Office of Rural Health Policy, Health Resources and Services Administration, otherwise known as HRSA. Thank you so much for joining us today and sharing your expertise on COPD in rural America.
Thank you for the opportunity.
And thank you all for listening. If you enjoyed today's episode, please go to iTunes, Stitcher, Google Play, whatever your favorite podcast app might be, and subscribe to Rural Health Leadership Radio. If you'd like to continue the conversation of leadership in rural health, you can also join our LinkedIn group called Rural Health Leadership Radio. And while you're on Facebook today, give us a like. Yes, check out Rural Health Leadership Radio's Facebook page, and we always love likes. Until next week, let's keep working to improve rural health, one conversation at a time.
If you would like to connect with today's guest, please send an email with your contact information to bill@billoxier.com. If you would like to be a guest or suggest someone else as a guest, have a question you would like to ask, or simply want to contact Rural Health Leadership Radio, please use that same email address, bill@billoxier.com. That's BILL@BILLAUXIER.com. You can also visit our website at www.rhlradio.com.
And we'd ask that you please support our sponsor, the Dynamic Leadership Academy for Rural Health. The Dynamic Leadership Academy for Rural Health's mission is to improve rural health, one leader at a time.